Thank you very much, and thank you all for coming at this time of the day after heavy lunch. And thank you all the organizers for giving me this opportunity to speak to you. I do not have any conflict of interest for this particular talk. So about a week ago, I was sent an email by the organizers and giving me a case discussion. So I'll start with the case discussion. Then I will discuss the incidence of anemia. I'll touch base about a little bit about hypoxia and physiological mechanisms to compensate for that hypoxia. And what are the outcomes of anemia in relation to the cardiac surgery? And when is the time when we need to intervene, or the point at which we should avoid that particular stage? And lastly, discuss a little bit about patient blood management system. So the case given to me was a 61-year-old gentleman admitted with angina. He is hypertensive, double vessel disease, low normal ejection fraction with hemoglobin of 7.2. It is microcytic hypochromic basically, which generally indicates iron deficiency anemia with the red cell volume is low and the hemoglobin in each cell is low, so basically indicating iron deficiency. Normal LFTs, platelets are normal and iron levels are low, and they have done the occult stool blood, which is not positive, which is negative basically. So I'm not a hematologist, neither a gastroenterologist, but just quickly touch base upon the causes of microcytic hypochromic anemia. The most common is, of course, iron deficiency. In the Western world, it is blood loss, usually from the GI tract, and in other countries, especially India, I think, if I'm not mistaken, nutritional deficiency is the commonest cause of iron deficiency anemia here. There could be some metabolic problems related to iron absorption, and there is a term called iron-resistant iron deficiency anemia, where patients, despite having good oral or IV iron, they do not take part into using of this iron for hemoglobin. And then, of course, rare cause is thalassemia minor, and there is anemia of chronic or chronic inflammatory disease or anemia of cancer, and others are lead poisoning. So anemia before cardiac surgery, if you see the literature, there are different reports. It varies from anywhere from 16% to 54%, and severe anemia, as defined as hemoglobin less than 10 gram %, is about 5.5%. So this particular study, they found that the anemia was in about more than 1/3 of the patients, and the risk factors basically were old age, chronic kidney disease, patients having peptic ulcer disease or gastroesophageal reflux disease requiring PPIs or H2 antagonists, and lastly, patients on diuretics. This is an audit report published just a few months ago in 2016 in Anesthesia. This is an audit from the UK, 12 cardiothoracic centers of the last 3 years. And they found that, again, 1 in 3 patients in UK is still coming with anemia for cardiac surgery. And the risk factors, again, was old age, diabetes, and high Euroscore. That means sicker the patient is more likely to have anemia. There is another term called hospital-acquired anemia. When the patient comes to the hospital admitted with normal hemoglobin, usually because of the interference or iatrogenic reasons, the hemoglobin drops. If comes with a mild anemia, usually can become severe in 2/3 of the patient. And that definitely almost increases the stay and the cost by almost about twice. The factors include perioperative IV fluids, the procedure of blood loss because of either surgery or any procedure, excessive use of blood tests, and of course, the chronic disease can cause impaired erythropoiesis because of the iron-related issues. So basically, why do we need oxygen? That is I'm talking here in front of you, standing, you're listening. We all need oxygen. Every cell needs oxygen. We can even do Trans-America race if we have good oxygen in our cells. We're very happy. But when we have hypoxia, either it is anemic hypoxia, which is the commonest, or cardiac factor or a respiratory factor, the cells suffer and they try to compensate that with different mechanisms. The commonest being they try to optimize the tissue oxygen delivery by nitric oxide synthase, and secondly, they try to adapt themselves by releasing hypoxia-inducible factor so that even despite the hypoxia is there, the cells try to minimize their metabolism and try to adapt to the new circumstances. So basically there are two hypotheses of how cardiac output or how the cardiac physiological changes occur in anemia. So one is the vasodilation because of the decreased viscosity, that is a passive theory. Whatever the theory you take, ultimately there is increased cardiac output in patient with anemia. That is because of increased heart rate, increased stroke volume, because of sympathetic stimulation, vasodilation in combination with increased tissue extractions of oxygen, causing decreased mixed venous oxygenation. This is in a normal situation, but when we have a patient with a vascular disease, and this prevents these compensatory mechanisms. So most of our patients do have these vascular problems. That is why they're coming for surgery. I would like to show this particular animal study, which is very important. And they studied animals with normal hemoglobin, normal cardiac output, normal delivery to the brain. So they measured the oxygen gradients from arterial PO2 to the capillary PO2 and the brain tissue PO2, and there was no production of hypoxia-inducible factor. Then they bled these animals and brought the hemoglobin down to 60 or 6 grams per liter. The cardiac output immediately increased. The oxygen delivery to the brain did suffer, but not to great extent, and there was sign of hypoxia-inducible factor release, but that was late at 18 hours. And now they added beta blocker to these patients and these animals, and see what happened. So same hemoglobin, which is 60, that is anemia. The cardiac output rise was there, but not as good as without beta blockade. The oxygen delivery to the brain suffered a lot, and there was very early induction of HIF, indicating that if you add beta blockers and in a patient with cardiovascular disease, that is the typical R patients, the anemia is going to not having that compensatory mechanisms, and our brain or other tissues will suffer. This is another study which is old but still very relevant. They did it on Jehovah's Witnesses with normal cardiac function and with patient with cardiac disease. With hemoglobin of 12, the mortality was almost 0 or less than 1, and as they dropped hemoglobin to 6, the mortality rose to about 2 or 3% in patients with no cardiovascular disease. At the same time, patient with cardiovascular disease, starting hemoglobin 12, but when it dropped to 6, it was exponential rather than stepwise fashion. Again, indicating that patient with peripheral vascular disease or with who cannot compensate because of anemia, so they suffer a lot. They have more post-op complications. Again, back to that audit report. The anemia resulted in blood transfusions and the odds ratio of 2.75. And if you have anemia, the mortality, of course, goes up and increases the hospital stay. And interestingly, they said a drop of 1 gram % of hemoglobin, just 1 gram, increases the odds of mortality by 16%. And they also mentioned in their discussion that the females, normally in the Euroscore, they add that 1% extra risk for female gender. And they say the normal hemoglobin value of female is usually 1 gram less than the male hemoglobin, that is 12 compared to 13 grams. And probably this could be one of the factors that females have high morbidity and mortality because of the cardiac surgery. These authors, they try to incorporate anemia into their Euro 2 score with their complex model, but ultimately found that if there is no anemia with the same cardiac surgery, mortality 3.4%, mild anemia, mortality doubles up to 7.7%, moderate to severe anemia, which is in our case, mortality further doubles up to more than 15%. So our patient lies in that the last thing. Coming to how low is too low, when either we should intervene or we should do all our efforts to prevent to reach to that stage where too low, the low becomes too low. Another very significant and important study which says hypoxic signaling, which is different in different organs. So kidneys, they have expression of HIF, and because of that, it causes the EP or release the erythropoietin. With the liver, with hypoxia, that produces hepcidin. Now hepcidin is known to be very much active and involved with iron metabolism, iron absorption, and recycling of iron. The nerves or neurons also release nitric oxide synthase. That happens at a hemoglobin of 9 gram percent. For kidneys and liver, the same thing happens between 7 to 9 gram percent. Whereas compared to heart and brain, they can tolerate this hypoxia because of anemia at much lower level, and that is because there is disproportionate increase in the blood flow. And again, this is an animal study with normal vasculature, no cardiac disease, no beta blockers, but still brain and heart have more threshold to tolerate anemia compared to kidneys, and that is why kidneys are also known as crit meter. When the hematocrit drops, kidneys are the first to respond to increase the erythropoietin formation so that they can produce more hemoglobin. How do we correlate that to a clinical setting? This is another excellent review article in which they combine different studies, and this is for respiratory failure from hemoglobin of 10 dropped to 8, not much difference in respiratory complications. After that, it keeps on becoming more and more. Renal morbidity again dropped from 10 to somewhere around 8.5 or 9. There is not much change, and after that, the renal morbidity keeps on increasing. Cardiac dysfunction, which is shown in green here, again, that starts here somewhere around hematocrit of 22 or hemoglobin of 7 or 7.5, then there is sudden increase. Similarly, the mortality up to hematocrit of 22 is not that bad, and after that it becomes exponential. Same with the stroke or brain, up to hematocrit of 22, which is dropped from 30, not much difference, and after that it again becomes more. So our magic number lies anywhere of hematocrit between 20 and 24, or in other words, hemoglobin of between 7 and 8, when we have to kind of try to prevent to fall into that range, or we have to do something. So our patient whose hemoglobin is already in this range, and if we do surgery on this patient, we already expect lots of complications in our patient. We know blood transfusion saves life. Blood is a tissue, is a fluid, liquid tissue, and some people say that it should be treated as an organ transplantation, the blood transfusion. It should have very specific indications. In that case, it can save lives. But if we use discriminately without much indication, for example, if liver transplant is indicated in end-stage liver disease, it will save life. But if we do liver transplant in the patient with mild liver disease, it is not going to be helpful. It will still be prolonged, but the mortality would be much higher than a normal thing. So the same with anemia. And surprisingly and interestingly, if anemia has, say, X number or a percentage of bad outcome, blood transfusion is well known to be an independent risk factor of mortality morbidity of its own. But when we combine anemia and blood transfusion, very common in cardiac surgery, the outcome is worse than combined risk factors for these two, which is quite interesting. That is why anemia and combination of blood transfusion is worse. Dr. Deepak Tampe and I have just written a review article on anemia and sent for publication to one of the journals. And this is the slide or the thing I have taken. Again, the problem with restrictive versus liberal transfusion, this is something like A protein in saga, where pendulum is going back and forth. So initially we knew that restrictive is much better and we should use in all patients. But you see, all these trials are mainly critical care post-operative trials, in which all say that restrictive is better. Of course, it is better. The hemoglobin threshold of 7 or 7.5 gram percent. Look at these trials when they take the patients for intraoperative cardiac surgery. Restrictive was not superior to liberal strategy. Liberal strategy reduced cardiogenic shock, the liberal strategy reduced cardiogenic shock. And this is important, these two papers, this came last year. They had 31 randomized controlled trials, and this divided, they took out the papers in which there was only intraoperative cardiac surgery patients, and they found liberal was better in cardiac surgery and high-risk patients. Of course, in pediatric, there is not much data available, and that still supports the restrictive strategy. So I'll take that anesthesiology journal published July 2016, and that is a subgroup of cardiac surgery patients in which they clearly indicate that this favors the liberal strategy. So that is better in elderly patients, high-risk surgeries, and especially in cardiac surgical patients. So pendulum has slightly swung from strictly restrictive to now possibly maybe we have to change our definition of restrictive strategy. We need to be a little bit more proactive, because if we combine anemia and blood transfusion and surgery, the results are going to be bad. So this is one trial by Acute, which they tried to transfuse the patient about 1 or 2 days before surgery. If you're pretty sure that this patient is going to need blood transfusion, it is better to give them beforehand, not combine with the stress of surgery, anemia, and blood transfusion. And they found good results. Last section of my talk, patient blood management. I just saw one textbook written only on patient blood management. Is of course in thing nowadays. I'll not spend much time. It was discussed already in the pre-lunch session. It's a multidisciplinary approach. You check hemoglobin at least a month before. There are algorithms to manage that. So we try to improve patients' own hemoglobin whatever way. We try to prevent hemodilution by your IV fluids and by bypass circuits. We reduce the blood loss intraoperatively. Restrictive transfusion strategy, I put a question mark. Probably we need to redefine the number for restrictive. I think probably in my personal experience, probably should be around 8 or 8.5 rather than 7. And of course, point of care tests definitely help in managing these. So example of this, Ontario Transfusion Coordinators, they met in 2002 for this particular program. At that time, our CABG transfusion rate was 60%, and that dropped to 25% in 2011. So the strategy does help, but it is a multidisciplinary approach. Everybody has to be on board. So this is again taken from the latest guidelines. So stop antiplatelet therapy, start iron and APO to increase the patient's hemoglobin. If we have time, use of tranexamic acid or Amicar. Use the cell saver, and the washed blood is important. If possible, OPCAB, definitely if there is one clear indication of the OPCAB better than regular cabbage is saving the blood loss and reducing the transfusions. Using minimal mini circuits, retrograde autologous priming, which is standard in our center, and lastly, use of modified ultrafiltration. So in conclusion, let us go back to our patient again. So our patient falls into high risk category, and we expect lots of serious complications. So if this patient I was supposed to do, I would definitely like not to proceed with the surgery if we have time. And we try to do some more tests, what is kind of anemia it is, start IV iron therapy. Very commonly in our center, I have a couple of cases like this, and we investigated, there was a carcinoma colon. Now there's a debate, that ethical dilemma. We treat cancer first in a patient who has significant coronary artery disease with anesthetic challenges, versus do we do the bypass, then wait for 2-3 months, and then tackle the carcinoma. So that is a very difficult decision to make. Everybody has to be on board that which needs to be done first. But again, we try to at least rule out what is going on. If we think that patient needs blood transfusion, it is better that we do it pre-op, like giving a couple of units of blood products beforehand. If patient surgery is urgent, surgeon really is wanting to do that. And of course, if there's a choice, either do PCI, that is another option. If not, try to do it OPCAB. Otherwise, we expect high complication rate. So in conclusion, under current models, unfortunately, anemia is not considered a risk factor for survival after cardiac surgery. But Pre-op anemia should not be considered as innocent bystander. It definitely has major significance, and there is convincing evidence that showing strong association between anemia and post-cardiac surgery mortality and morbidity. And lastly, correcting and preserving patients' own hemoglobin before surgery is very much possible and should be attempted at all costs. Thank you again for your kind attention.